20?
Okay.
Alright, so one of the things, what do you think, as therapists, we work with our patients, what do you think when you first meet your patient is, what do you think we need to do? What do you think is very important for us in order to really get that patient to want to work with us, and even for us to accomplish the goals that we want, Isaiah? You want to make them feel comfortable. So I can go in with patients, and again, if you guys have any experience in any other customer service type of job, or any job where you actually have to work with people, you work better with somebody that you develop that rapport with. Our patients come into us, they're pain, they're vulnerable, they're scared, they don't know this, they're not studying this, so they have no idea. So they're really trusting us. And I say this all the time, I think we are better at understanding a diagnosis or what the patient needs than the doctors. On average, how long do you think a doctor spends with a patient? And it's proven.
15.
You say 15?
Yeah. Like 5-10 minutes.
It's 5-10. Anybody else? 3. On average. It was shown in many studies, a doctor spends 3 minutes with the patient. What can be done in 3 minutes?
A prescription and that's it.
Nothing.
Yeah.
So for us, as we get these patients, and we're there, if you're in a rehab center 5 days in a row, if you are outpatient 3 days a week, every day in a nursing home, that type of stuff, you really get to know the patient. They tell you things that you don't really want them to tell you, number one. But again, they're trusting you. And that's what's most important. So let's first develop that trust. And we do that by making them comfortable when they come into our environment or when we go into their environment. I go into people's homes. So I'm going into their environment. So I have to respect their wishes. And one of the things I love, absolutely love, about home care and even working and living in this area is the diversity. So I love going into Asian people's homes, take my shoes off, walk around and learn about their culture and heritage. The Muslim people, same thing, take my shoes off and go in. It's awesome. And so that's what we have to do. So we can't just be with these patients and say, hey, I'm the therapist, you have to listen to me. No. You're control. This is your health care. You are in charge of your health care. I'm working for you. Yes, I'm the professional. I will give you everything I know to get you better. We will work together. And that's that relationship we have to build. And so it's getting that patient comfortable with us and then them in that environment. So we do that, positioning, draping. If we don't get that patient comfortable, say they come in with back pain, they're lying on the table, there's still a lot of back pain, it's going to be very hard for us to do our job. So, first thing we do, we go to the patient, we want to let the patient know who we are. So we're always going to introduce ourselves. When we start doing our practical, when we start doing our practicing, it's always going to be, hey, how are you? I'm Tom, physical therapist assistant. I'm going to be working with you today, or I'm a student. Yeah, so I want to make sure that I'm actually working with Brian. There were times that we had students at once, but you'll see it out there. There were times we had a student, the therapist said, hey, you know what? Can you go treat Brian in room 20? He goes up to room 20. Brian had been in room 20, but they switched. He went to a different floor because he's getting ready to leave. I come in, hey, Brian, how are you? Let's go do this. I walk out. I need the chart. And I write the wrong note. And they said, what? I thought you were going to see Brian. I did. He told me he was in room 20. No, Brian moved. You saw somebody else. Well, now I suppose I see him, and all of a sudden he had a shoulder fracture where it was no range of motion. Don't touch the shoulder, but I do. So that's why the identification. Introduce yourself, identify the person. Hey, what's your name? Can you tell me what your date of birth is? All right, let me look on your tag. Okay, I got the right person. It's also a way for you to determine their cognitive status, but that's down the road. because there's so many times you would see a patient, especially in the older population, where they're great, nothing wrong. Then you go in and they're confused, they're angry, and now they have a urinary tract infection. And like I said, we're with these patients all the time. We are the ones that really should pick that up. Okay? All right, so identify yourself, identify them. So we're using position and draping to protect their modesty. We apply belts, sheets as needed. You go in to get your physical. What's the worst, well, before you get to a certain age, what's the worst thing that you feel when you go to get your physical?
Shots?
No, no. You go in, the doc, what do they do? What do they tell you to do?
Pull your pants down.
Yes, take your clothes off. Here's a gown. So the modesty, people that are insecure. Am I going to really be comfortable, or is somebody going to be comfortable with me if they're insecure because their butt's hanging out? Yeah, when you get to a certain age, you don't care. Doesn't matter. I go into physical, and they put me on the scale. I'm like, wait, you're going to weigh me with all my clothes on? Like, come on, man. Like, I'll strip naked if you want. I want my real weight. I don't want those 3 pounds. It frustrates me. So they walk out. I strip down. Okay, good. All right, so who is it? Hand raise. You're good? Okay.
We have this PowerPoint, right?
Yes, it was sent to you. Do you have it?
Yeah, I
What's
just
the
Just
date?
make sure
I
you
just
check.
got it, yeah.
Good, excellent.
Thank you.
It was sent this morning?
No, it was sent yesterday.
Okay.
So check it. Break it here.
Another aspect of modesty
Yes.
too, guys, could be like religious beliefs
yeah.
Introduction.
and like whether
Is this it or
they're
bottom?
No,
comfortable
bottom of
working
That's it right
with,
there. Yeah.
like
Good.
working with a male, working with a female, whether their religion allows it, whether they need to be covered or not. Those are important aspects of modesty.
Yeah, absolutely. So provide clothing, shoes, etc. Keep the patient warm. So when you do work with your patient, if say you're doing something to their neck and they have a necklace on, and they go, can you take your necklace off? And they hand it to you. No. Or watch if they're doing something with their arm. Like, nah. Let them. You can take it off for them, but make sure you give it back to the patient.
What if a patient has like a hijab or something, and you have to like check out their neck, and they don't want to take it off? Do you just put down refuses to, or does not want to?
Yeah, you certainly would want to document. I wouldn't say refuse. That's harsh as opposed to, hey, you know what? Personal beliefs. Patient, was not willing to, take off, whatever it may be.
For religious purposes.
Religious
yeah.
purposes. But now then that becomes a conversation. Hey, you know what? If you feel more comfortable working with somebody that understands that that's the same religion, then you want to really go out and find somebody. If it's in a hospital, all right. Like there were so many times like when I worked with kids, like I would want the parent there. I had a woman who had surgery, piriformis syndrome, where she had to get surgery to cut the piriformis so the nerve wouldn't be compressed anymore. And I'm like, to the husband, I need you in the room here. And she's like, I don't care. No. For me, I need you in the room. Because I don't want all of a sudden her word against my word of, well, he was inappropriate. So if you feel uncomfortable, always bring another therapist in. Hey, Brian, do me a favor. Or if it's a woman, hey, do me a favor. I'm going to do the evaluation. Just sit in here with me. Hey, I have my colleague here. She's just going to, help me out because I think, 4 eyes are better than 2. She can help me pick some stuff up. I'm not saying I don't trust myself being in here with you, or I'm afraid that you might, say something to my supervisor that I was inappropriate. I'm not going to say that. Say I just haven't, she's going to be here to help me, with my evaluation, with my treatment. So you always want to protect yourself.
Another aspect of that too is like ask them where they're comfortable. Like where I work has a lot of Muslims and Hasidic Jews, so like the women can't be seen. They'll be seen by a female therapist in a private room and have no issue taking anything off. It's so like just ask them where their comfort level is because they might be able to meet you in the middle.
Yeah. All right, so our positions. We're going to treat patients supine. On your back. Prone, sideline, and how about these? SSP? No.
Side.
Short seated position. That's regular how we sit. And then LSP, long seated position. So if you look at Lindsay, she's in a long seated position. Okay? Long seated position, and then short seated position.
Oh, short-seated.
That's short seated position. Yeah. All right? So again, it depends on what kind of treatment we're doing, how much balance they have. That's harder to sit at the edge of a table for somebody who has very poor trunk control as opposed to the long seated position, because now they have their hands and they have a much greater base of support. So your question.
What's prone?
So prone will be on your stomach. Okay? And so really the key is let's get this patient as comfortable as we possibly can. Rationale for positioning: prevent soft tissue or joint contractures. Anybody know what a contracture is?
Like a spasm or
Not a spasm,
just
Tightening?
a tightening. So a tightening. Lindsay had she had ACL reconstruction, which she did.
I did.
So you sit here. So now she's lying down and on your back. So she comes in for therapy.
Ooh, sorry.
And she goes home. It's like, oh my God, my knee is so painful. Which it is, because the surgery. My knee is so painful. No one tells her that, you know what, or her mom's like, oh God, I feel so bad for you. Let me put this pillow under your knee. Like, how's that feel?
That feels great.
Good. Oh, mom's like, oh, thank God. And then we walk away, and then 8 hours later, she wakes up. What's going to happen to that knee?
It's gonna be tight.
It's going to be tight. It's going to be stuck. Now, she does this for a long time, comes to therapy, and now she's walking, and I can't get my knee straight. She sees the doctor. We get a phone call. The doctor's ripping us apart because we didn't do the right stuff. So knee replacement, ACL reconstruction, you don't want the knee to bend. So the rationale for positioning, preventing soft tissue or joint contraction. So now instead of doing it this way, you know what? Let's just do it the long lengthwise, because now I get that knee straight. Whether it's this, we're going to talk about a little later on somebody who had an amputation, they sit in a wheelchair all day. What's going to happen? Look at us. What do we do all day?
Stand.
Baloney.
Oh, wait, I thought you meant as a physical therapist.
Well,
As a human.
yes, right.
Just as a
Oh,
human.
Yes, we do.
Oh, okay.
What are you guys doing all day here?
Oh, we're sitting, yeah.
So what happens when you sit? What muscles get tight?
Psoas muscles.
So our hip flexors get tight, our hamstrings get tight. So now you get somebody who had surgery, amputation, they're not moving in a wheelchair all day. Those muscles get tight. So that's what we want to avoid. But we can use positioning to help prevent that. We use it, positioning for comfort and modesty. And we're going to get into draping as well. For support or stability, again, if they're sitting there or they're lying down, we don't want them rolling or being out of posture or out of control. We can use that positioning, again, to keep them stable. Makes it easy for us to treat. Expose the area to be treated. So if I'm working with somebody with the low back, I want them prone so I can see the low back. I want them comfortable, because then this way, if they're comfortable and the muscles are relaxed, I can work on the area or work on the specific muscles that need to be worked on. Efficient function of the organ systems, and then preventing prolonged pressure to all structures. We're going to learn later on, but we're going to get into what happens when somebody lies in one position too long. Let's say an older population.
Bed sores, yeah.
Bed sores, yeah. Pressure ulcers are caused by too much pressure, usually on bony prominences. So I want to use this positioning to help avoid that. I also want to make sure the patient turns. Every hour and a half or so, we turn the patient.
2 hours.
2 hours, I know, the book says 2 hours, so go by 2 hours. All right? So, draping. Let's see. So, draping. Draping is just like, so using a towel, using a blanket to help. So, say we can maintain comfortable body temperature, protect the patient's modesty, being sensitive to culture, religious beliefs. And so, Dawn, that's what you had mentioned before. Okay, if it's, again, a woman that doesn't want to be seen or can't be seen, maybe go into a private room, but then you cover them up with a blanket and work on the area. Have access to the body part being treated while you're protecting other areas. And then when you're working with the patient, again, if you ask them to take their clothes off, just make sure they know where they put it, have them take care of that. And then with lower extremity, may need to provide in-between sheet. And I'll show you that right now. So, who wants to be the patient for now? I'll be the patient. You great. All right, so let's say, just in general, you can do some ankle or do some knee work.
Newark. So I'm making sure that, a lot of times they're in a bed already, so making sure that no matter how I bend this knee, it's gonna be, he will be protected. So this way even when I come up, are you okay?
Yeah.
He's still protected, so there's enough blanket wrapped around. So I did not have your name.
So the one place I started working at, we would get these old guys that come in, and they would either wear just boxer shorts or very loose shorts, and you'd move them around, and everything would be on the table. And they didn't care. But maybe they didn't care, but yet somebody at a table across the way or somebody else nearby certainly didn't want to see that. And that's when you would want to provide the draping. Like, you know what, we don't need to see that. But at the same time, say if it's a woman, young girl, whatever it may be, she's wearing shorts, and then we have to do some hip abduction work. You know, maybe we're doing some lateral rotation of the hip. Again, they're going to be insecure about that. We want to keep them modest. We also don't want to expose anything else out to the clinic. And so that would be that in-between pillow. That would be the towel, the blanket that you would drape over them to maintain that modesty. So now you can do some hip abduction. And it's all good. All right?
Good.
You can go more.
Okay. It's like, are you fighting me? Or
No, that is always tight. Right? So that's how you would drape like this position. Suppose then you want to do some low back work. And the patient doesn't want their butt sticking out into the entire clinic. Yeah, so I lift up.
I also tuck in just to protect their clothes a little bit. And pull down.
But the draping, the blanket also keeps them warm. A lot of times, if these clinics, therapists work and the clinics get the air conditioner, whatever, gets cold. So this helps keep the body warm. All right. Now, if say,
You're gonna have a tail.
again, I'll say even if you want to work on the shoulder, and you ask the woman, hey, can you take your top off? I got to do ultrasound. They don't want to lie there, just the bra exposed.
I like to tuck. This way it doesn't move too much if I move them.
Yeah, and so she does some shoulder work. And again, everything is secured. I'm comfortable. I'm not sitting here looking around like, hey, who's around? Who's going to see, what I have, that type of stuff. So that's why we would want to drape. All right, the modesty, keep the patient warm. Really mainly keep the patient comfortable. So all that leads to having a successful treatment. All right? And like Lindsay had said, I asked them, are you more comfortable in a private office? I don't know if you guys, if you work where you work or had worked or volunteered, a lot of these outpatient therapy places are just wide open. It's easier for the therapist. I personally rather prefer to work in a clinic that was wide open. So if I had patients doing stuff, I could be like, oh, here, let's do it. You're not doing that right, let's do that. While I'm over here working with somebody. Some have the curtains that you can pull. So you really want to ask the patient, are you comfortable working here? Because we can certainly go to a private room, or I can pull the curtains. All right, we good with that? So that's the draping. Now, when we talk about positioning, again, that was impressive. Oh, this is very nice.
Thank you.
So we want to be careful about positioning. Again, it's going to be, are we getting this patient comfortable? If they're going to be in that one position for a long period of time, or are we going to get other type of complications? So precaution with positioning, smooth out linens and clothes to avoid folds. If you have these folds, the patients that might have like thinner skin, patient that might be on Coumadin, which is a blood thinner, again, too much pressure on the skin could cause it to break down. And so you want a smooth area, you want it as comfortable as you can possibly be. Be observant of the skin prior to, during, and after treatment. So we talk about, we're with our patients a lot. I might be the one that if I'm working with the patient and I notice like, hey, you know what, geez, I know you've been lying down, I see some redness outside your leg. And then it doesn't go away. Well, I better be the one that calls the therapist and, my supervisor and say, hey, patient I have has a little redness there. Can you take a look at it? I'll document it. Treated the patient today. You observed 1 inch by 2 centimeter by 1 centimeter red area at the fibular head. Notify supervising therapist. We'll follow up with MD. I did my job. Now I come back and all of a sudden it's bleeding or it's a big crater. Well, we got to make sure that that we notice that. So again, before and afterwards, you're going to look and observe the skin.
Assuming you come across a situation like that, and that's the area that you have to treat, but you don't feel comfortable treating like the area because of that.
To cut you off, if she was my patient and I was doing stuff for the knee, and all of a sudden I come in, I see a big wound, whatever I'm doing for the knee, that is the least of my worry now. Now I'm concerned about that wound.
Yeah.
Hey, you know what? Are you aware of that? Yeah, I saw it. It happened like 2 weeks ago. It's green, it's black, it doesn't look good. How about you go to the doctor right now? Hey, doc, you're gonna send somebody in. That becomes your more of a concern than, yeah, she was here for arthritis for the knee with diabetes, and now because of the lack of blood supply, this has become a grade 2 or grade 3 wound, and before you know it, the whole leg gets taken off. So that's where that at that time becomes important. You're always assessing, we're always observing what's going on, because with our population, things change every day.
Right.
I was telling these guys a story, not that it's anything related to a wound, but I was working with this woman who, for her hip, she had hip fracture. I go to the house yesterday, ring the doorbell, no answer. Call the daughter. It's like, oh no, I think maybe she went shopping. And then like a phone call later, it's like, oh, mom passed away in her sleep. So things change. She's normally a healthy old lady. Things are going to happen. And we have to be the one. Again, you're not physicians. You're not liable, to realize that, gee, I think she has, an aneurysm. We don't know that, but we will know if there's certain changes, and we should be able to pick them up. And you'll get better with that as you experience and do more.
Yeah.
All right.
So can you choose to, like, for whatever reason, if you say things change, like, not provide treatment or a very, very.
What would be better? What would be better?
I think
You're being ultra cautious and say, you know what? I don't like what's going on here. Let's go to the doctor. So you missed today's treatment. She goes to the doctor, and the doctor's like, you're good, you're fine. Tell a therapist you're fine. Yeah. As opposed to like, it doesn't look like it's a big deal. Let's not worry about it. Yeah. And then 2 days later, she comes back with this giant wound that's infected, and now all of a sudden she has to go in and get surgery for that, or an amputation. So you always want to err on the side of caution.
Yeah.
So the worst thing that can happen, hey, listen, I apologize if I was, being overly cautious, but I just really wanted to make sure. Yeah, so if you feel as a professional that I don't think it's a good idea to treat you today because I'm concerned about that, let's, talk to my therapist. Yeah, you're good. All right, as long as you document it, you're fine. All right? The other day, when we talk about, yesterday I was telling the class, even a woman went to get a pedicure. About 2-3 months later, she was an above-knee amputation.
Oh man.
because that toe had gotten infected, and then it just kept on moving up, and she wasn't getting therapy because she was normal. I got there after the fact, but it just kept on moving up, and then by the time she went to the doctor, the infection had spread in her blood up to about her knee, and then it became from a pedicure to an above the amputation.
Wow.
Yeah. That doesn't happen a lot, or it's very rare, but yeah, stuff like that can happen. You
Yeah.
come across some pretty strange stuff, right? I mean, if you're in your experience, just some, you're like, really? That's how that happened?
Oh yeah. I feel like it's more frequently like that's how that happened versus like, oh, that makes sense.
Yeah. Yep.
It's just great that the patient themselves don't even like notice it. They're just like, oh, my skin's turning like black and green. That's fine.
That's fine. It'll get better. It'll get better. Yeah, that's no big deal. It'll get better. Of course, it'll go away. I mean, how many people are afraid to go to the doctor because they don't want to get the bad news? You get patients that, like, they haven't. When was the last time I went to the doctor? Like, I don't know, 30 years ago. I got a 98-year-old aunt. She hasn't been to the doctor in like 20 years because she doesn't want to hear what's going to happen. Yeah, she's doing something right, but they don't want to. When's the last time I went to the dentist? Oh, forget that. 30 years or whatever it is, yeah. So, all right, so positioning, so we talked about pressure. So anytime you position, you want to be cognizant of the bony prominences. So when somebody lies in bed all day long, and you're in a nursing home, where do you get a lot of those pressure sores?
PSIS?
PSIS, but also the sacrum. Right, they're lying there, that bony prominence. Older population, the skin gets thinner. Their muscles get sort of, I don't say weaker, but less tone. And so now you have a greater chance of gravity and that body weight pressing on the table, and what really comes through is going to be the bony prominence. And that's where you get the breakdown. Also, older population that are incontinent, and they're lying in a diaper. Urine is very, very acidic. What happens to acid on a surface? It can burn it. Not necessarily burn it, but yeah, it can certainly disintegrate it. And so it's very easy. You can go in, I've seen this happen numerous times. You go in and you see just a little reddened area. You see the patient 2 days later, now they have a big crater because of the pressure, because of the urine, the feces, all stuff like that, right? So in position, we want to be careful. We want to avoid that.
For an elderly patient, how would you avoid getting like bed sores when they just
Move.
if they can't like really move around?
Then what I teach as a therapist, I would instruct, who do you have here? Private aid? Is it family members? I will teach them how to move them. And so my treatment might not be individually working on this older patient, on the patient. You know what? She hasn't walked in a number of years. She's been in bed ever since. Well, then what we're going to do is I'm going to teach you, let's do some range of motion just to keep the blood flowing, but I'm going to teach you how to move this patient, how to position them. So they start supine. Let's just get them rolling on their side. So that's what you would want to do. The best way to treat pressure ulcers is prevention. And that's where Lindsay wrote, turn patient every 2 hours to prevent pressure, ulcers, and sores. And so that becomes a real big part of the treatment session, is making sure they move. Or getting equipment. If they go into a wheelchair, get equipment that they can move. All right? So positioning, again, pressure. So this is for the head and the trunk. So if you're supine on your back, your occipital protuberance, right, that occipital ridge. Spine of your scapula. So these are those bony prominences that really stick out. Inferior angle of the scapula, spinous process, PSIS, and the sacrum. So if you're supine for your spine and your head, those are the areas of concern. If you're prone, forearm, forehead. If they lie on their side a lot, the ear. Acromion process, sternum, ASIS. Sideline, lateral ear, ribs, chromium process. If you're sitting, ischial tuberosity, huge. And also your sacrum, right? that ischial tuberosity is pushing right down through that skin. All right, for your upper extremity, if you're supine, median epicondyle, or of the humerus, if you're prone, the anterior head of the humerus. You read this up on your own. I need to go through it. But what you need to know is that just be cognizant of those bony prominences. All right, so this is pressure on the upper extremity in each position, on the lower extremity in each position. And so if Lindsay's lying down, send me back. And so think about, let's not do that yet. So she's lying, and normally, right, just because of the way our hip or acetabulum is positioned, right, with the angle, we're always going to get that lateral rotation. So that's the normal position, toes are out. So what do you think in this position for too long? You've had some palpation, you've seen the anatomy. What positions, what parts of the body, what bony prominence would you be concerned about in the supine position? For lower extremity.
Sacrum.
Well, yeah, so obviously your sacrum.
Calcaneus.
Calcaneus, definitely the calcaneus. What else?
Malleolus.
Malleolus, yeah, look, right? That malleolus is pressing on there. What else? Let's move up. Fibular head. Let's move up.
Sorry. Okay. That weird part of my leg.
Condyle. So, yep, the condyle. And then
Ischial tuberosity.
the greater trochanter. Yeah. And then PSIS. If she's sidelined, certainly the iliac crest. All right? So you got to understand, okay, in this position, if she's going to be lying like this for a long period of time, so maybe what I'm going to do is I'll just put a pillow on the outside, keep it straight. Or, you know what, let's take some pressure off that heel and make you comfortable there, all depending on the back. All right? So there's nothing wrong with you as a therapist putting your patient in positions that you know are going to avoid that pressure. But the best thing you're going to do is just have the person move. Okay, every 2 hours, just have that patient roll, you know, get them up out of the chair, get them in a chair, you know, if you can stand for a little bit, whatever. Good? Yeah, so you just go through that, and what is your bony prominences? You know, look at prone. If they're prone, you got your patella, so. All right, so what you're concerned, though, is if a patient's in one position too long, the contractions. We talked about that with the knee. So if the patient's supine, we want to avoid too much hip or knee flexion. So the contractions they can develop would be a hip knee flexion contracture. Ankle plantar flexion contracture. You lie down and you're in this position too long. Shoulder extension, adduction into rotation, and then your hips are externally rotated. Prone, ankle plantar flexion, shoulder extension, adduction, internal rotation, and neck rotation. So these are the contractions. This is the tightness that you would see. Sideline, hip, knee flexion contracture with the knee bent. Like think of the fetal position. You stuck there too long, it's going to get tight. And if you're seated, what you guys are doing now, in this position too long, your hips are shortening, your hamstrings are shortening. Maybe their hips are adducted or internally rotated. And then if their shoulders are forwardly rounded, what is it, rounded forwardly? Forwardly rounded? Same?
Rounded forward.
Rounded forward? The rounded forward. Okay, so those are the positions you want to be careful of. It's not saying don't put them in those positions. Just make sure that they don't stay in those positions for too long. So you know what we do? Let's do the actual positions, then we'll get back into this. And then we're going to talk about forehead. So, if I want to position somebody prone, let's start supine. So for supine, our positions.
Yep, found it. Thank you. I have no words today.
That's okay, that happens. All right. So,
Just pulling everything up here.
position supine. Pillow at the head. Obviously, it's comfortable. I'm also going to put pillow underneath the knees. This will keep the pelvis neutral. Because we learned our anterior posterior pelvic tilt, correct?
Yes.
So by putting a pillow at the knees, having slight flexion of the knees, what that'll do would keep that pelvis neutral. A lot of times if the knee, without the pillow, I can get an anterior pelvic tilt. What's going to happen to the spine with an anterior pelvic tilt?
Anterior pelvic tilt is extension. Yeah.
Right, so maybe I get more extension of the spine with an anterior pelvic tilt. Don't want that. So, prone, supine position, I would want pillow at the head, pillow below the knees to keep the pelvis neutral. What I can do for comfort is one pillow like this. I can do one pillow like that. If I'm concerned about the calcaneus, I can take a small towel and then just put it under the Achilles. So now the calcaneus is not resting on the bed. A very common area for skin breakdown. Lying in bed too long. Alright? That would be the supine position. Sorry?
Right, that's a lot of pillows.
She also did flaccid and
Yeah, we'll get to that
Okay.
too. Yeah, that's yeah.
she did that here, so I just wanted to.
Yep. Alright? So the key, when we ask you on the practical, okay, patient, position of patient supine for hip replacement. That's how you do it. And then we'll get into the other conditions a little later on. Alright? Now let's go prone. That's just the basic. So prone. First, lift the hips up. Pillow underneath the hips. What's that doing to the pelvis?
Neutralize.
Keeping it neutral. Alright? If I want, I can have the patient at the end of the bed. She's in a flexion contracture here, not she's plantar flexed here. Maybe that's not what I want. So I can either pull her at the end of the bed, or if not, stay there. Or I can do that same thing, where I would put like a towel or a roll underneath here, try to get as neutral as I possibly can. At the head. So not that way. Sorry. Yeah. All right. Is that okay for a long period of time? No. Let's suppose I'm working on her upper thoracic and her neck. By doing this, I'm shortening one side. So I can do a couple different things. I can have her put her hands like this, lying in the hands, so now the neck and the head are neutral. I can take a towel roll and make something like that, where she's lying that way. Or I can get one of these things. Sort of like a cervical pillow. So I'll do it because so you don't have to worry about that. And so now, you're lying down.
Oh, nice.
Now that makes it more comfortable.
Yeah.
Alright? So sort of like a cervical support, head support type of pillow. We can do that. For people that either work in massage or get massages, you notice like they have those cutouts.
The face shape.
Yeah.
towel.
I mean, it's for a reason. I want to get this patient comfortable. If I'm working on her neck and she's like, her head turned, like I said, I'm just shortening one side. I'm not really, getting the most effective treatment there. But using something like that, if you don't have that, resting your head like she's doing, can make it comfortable as well. That would be prone. Good? Sideline. So sideline position, pillow between the knees. What's going on at the pelvis? Neutral. Okay? Pillow at the knees, one at the head for comfort. I can put one here to support the shoulder. Keep that also in somewhat of a neutral position. Okay? Right?
Yep.
Yes.
That's sideline. You good?
think so.
You
was
bring
the-
the top knee over so they don't roll back.
Yeah.
What was the one for that, if you're just for the shoulder?
Comfort.
Just for comfort.
Comfort?
Yeah. Keep that again, keep that supported just for comfort. All right?
So wait, so these are like the positions you would put them in for like prolonged?
I can do prolonged if I know I go in, Lindsay, and she has a condition where she's bedbound for a while.
These would be like the different positions that you could turn them into.
Correct.
Okay.
But at the same time, this might be a position, and we're going to get to it in a sec, that I can use positioning, I can use gravity as a way to help my treatments. So, if I know that, Lindsay has a contraction or muscle tightness, and I only go in there and I work only for a half hour, do you think I can cure that tightness in a half hour? No. But if I know there are certain positions, let's have you go on your back. Let's say we go back to our ACL reconstruction. So remember when we talked about the contractures in the very beginning of this slides, where we say, she's in so much pain, but mom, being mom, wants to comfort her. And she does that. Whether it's a total knee or anything with the knee, this is not a good position after surgery because it's going to be short. Let's say they come to us a couple weeks after surgery and they're stuck like this. Now I can use positioning. I can say, I know it's painful, but let's not have anything under the knee. Let's put something at the lower leg, because now gravity is pushing down to get knee extension. So now I can use this positioning as a way to help with the treatment. She comes in with everything I need to do. I try to stretch. I only got a few minutes of doing that. But I say, hey, when you go home, do me a favor, watch TV, put your foot up on a pillow, put your foot up on the armrest. Let's get gravity to do it. She's binge watching Ozarks. And now, it's 8 hours later, and hey, look at that. That knee is stretched out because of what she did. So we can use that stuff to help. All right? So we're good with that. That's just the basic positions: supine, prone, sideline. All right? You guys need a break? Let's take a break. And then we're going to get back into the actual, we'll get into the
Okay.
detail. We're talking about total hip as well. Total hip replacement, the precautions, we'll do that. So, transfemoral amputation, or an above-knee amputation. That's where they go right above the femur, so the knee is gone. So think about that patient, especially early on. Walking might not be possible because they don't have the prosthesis yet, so they're going to be spending a lot of time in a wheelchair. Just like you guys, you drive down here, you sit here all day, you go home and you study, you sit for a long time. So we're concerned about that hip flexion contracture. And so we want to avoid prolonged hip flexion. Limited sitting to 40 minutes per hour. So what position would I teach that patient? Say, hey, you're in the wheelchair. When you get back into bed and you're watching the Yankee game tonight, I want you to go into this position. And what would it be? They can certainly do supine, but what's even better? They have been short sitting.
Maybe short sitting. Long sitting.
Nah, they're still sitting.
Prone.
Prone. So I'm sitting like this for a while. Now all of a sudden, hey, I want you to lie down and watch TV. Now they're doing this. What's going on at the hip? It's an extension. What position are they in when they sit too long?
Flexion.
Hip flexion. What contracture they develop?
Tight hips.
Hip flexion contracture.
Flexion.
So a contracture is termed sort of like by the direction it's in. The knee flexion contracture would be that the knee is stuck in flexion. Ankle plantar flexion contracture would mean that the ankle is stuck in plantar flexion. So they have a hip flexion contracture. If it's a transfemoral amputation, I'm going to have them say, listen, I need you to lie prone. Watch TV for 15, 20 minutes prone so you can stretch out the hip flexor. So for that, I wouldn't worry about the pillow under my hip. Because what's that pillow gonna do?
Neutralize your spine.
It'll put the hip in what position?
Neutral.
No.
Well,
Well, if it's the pelvis in neutral, but what's the hip?
and flexion,
The
barely.
hip is flexed. Right, the hip is flexed. So I don't want to do that. So now with that patient, maybe I prop up this way to get them comfortable like that. Hey, lie, yeah, so they're an extension. Lie like that for a little bit. Right? Lie prone to encourage extension. If they are a trans-tibial amputation or a below knee amputation, and they sit too long, so you want to avoid hip or knee flexion. So you can still do the same position, hey, lie prone for a little bit, or if they're in the wheelchair and I don't want that stump to dangle down, I can get what they call an extension aid. So if you have a regular wheelchair, and you've seen a wheelchair that has the leg rest,
Oh, yeah.
I can get something that, get rid of the leg rest, but get this extension board, and similar to the leg rest, but this thing elevates up, and now they can lie with that knee extended. Because what's very important with a below knee amputation is I better make sure that knee gets fully extension. Gets fully extended. Fully extension is not really grammatically correct. That I make sure that knee has full extension. Why?
I'm not sure because
Because it's still there.
So it has to do with the stump, but what are we training this patient eventually to do again?
the prosthetic.
The prosthetic. For the prosthetic to fit, so if that knee has full extension, we can get the normal walking pattern again. But if they're stuck, and now I gotta put a prosthesis on, that's gonna really affect the whole mechanics. I might not be able to get that prosthesis to work. So a full extension of the knee to be able to get back to normal gait. So with the with a below knee amputee, maybe an extension board. If they do want to lie supine, what I can do is, with the pillow, I can put a pillow along the entire limb, or at the lower part of the leg, just like we did with the knee replacement. Right? Did we do that? Yeah. Just like we did, right? It's your ACL. Just like we did. Now I get the knee extended. So I can use gravity to help, just like we did with the total knee replacement, but now it's just the stump that's here. All right? Yeah, I'm still concerned about the hip, so I'll still have them lie on their stomach at some point in the day for that. All right? So really what you're thinking about with certain conditions, if they spend too much time in one position, what muscles are going to get shortened, and then what can I do? What can I teach that patient to do to avoid that? We don't really worry about it. Yeah, I know we joke around and we say we sit a lot. We drive here, we sit here, you go home and you eat, then you study and you watch TV and you're seated a lot. Yeah, we do have tight hip flexors, but we also get up and walk, so we're not going to have the contractures. But these are that population that can't get up and walk all the time. So they spend more time in a wheelchair, more time in the bed. All right? Now, a hemiplegia patient. So hemiplegia, weakness on one side, obviously caused from a stroke. So a left CVA, what does CVA stand for?
cerebral vascular accident.
Yep.
Stroke.
Cerebral vascular accident, cerebral vascular attack. Right, so what you're going to see is what they have these synergistic, or these synergy movements, synergy patterns. You'll get that in a slide eventually. So a synergy pattern is sort of a gross movement of all the joints together. So somebody who had a stroke, if you ever watch somebody with a stroke, when they try to raise their arm up, everything will move together. That's a synergy.
How do you spell that?
Synergy. So, if my patient following a stroke, if they're going to be in this position, and they get that spasticity, they're in this position all day long, what's going to happen if they're stuck here in terms of function?
Shortened bicep
But overall, in terms of
overall.
if they're in this position all the time,
That synergy. That
they're going to have a hard time doing functional activities. Hey, let me go to the bathroom and they can't move their arm. How do I dress myself? So I want to avoid that positions. Yeah, so synergy moves together, spasticity, a lot of tone. Flaccidity is no tone, flaccid. So synergy, move together, lots of tone. Flaccidity, very low tone. So my patient's like this. All right? There's my patient. We're going to have her left side, lie down. So, she's stuck. The shoulder, glenohumeral joint is adducted, internally rotated. The elbow is flexed. The forearm could be either supinated or pronated. Right now it's supinated. Wrist is flexed, fingers are flexed. So, how do I want to position her?
an extension.
In extension of the elbow. What do I want to do with the shoulder? We talked about the shoulder being adducted, the glenohumeral joint being adducted, internally rotated. How do I want to position her?
Position the shoulder
Just the glenohumeral joint.
in extension.
So if we're adducted and internally rotated,
Abducted, externally rotated.
yes. Elbow is extended, so now I can get some pillows. We'll pretend that, we've done this. You're taking one. All right, oops. So I can have it abducted, externally rotated. I can say, all right, let's extend the wrist and the elbow. What do I want to do with the hand?
Extend it out.
I want to extend the fingers. But now I know that, she's going to be stuck there, so I can get a smaller towel roll and have her grab it, hold on to the towel. By having her grab a towel, a ball, I think there's a tennis ball on here somewhere.
Over there.
Yeah, here, I can do this too. This is better so you can see it better. What are the fingers doing here?
Extension.
They're flexing, but are they flexing as much as that? So I do have the fingers in somewhat of extension. So whether I get a towel roll, and I put that towel roll like this. So for my CVA, my hemiplegic patient, everything else will be the same. Pillow under the knees, keep the pelvis neutral. Pillow under the head for comfort. Now I'm adding a pillow under her shoulder to support the arm, but to get abduction, external rotation. I have the elbow extended. The elbow is extended, so I can use gravity to help stretch. And I have a towel roll, a hand roll, a ball in the palm to get the fingers to extend. All right? Make sense?
Yes.
So whenever I'm concerned about being tight, I just put them in that opposite position. Anything?
She told this way.
Did, what's that?
This is happened with Sarah too. She told this way.
Yeah.
This is why we all got our first round for our exam.
You're the opposite. Yeah. Yeah, so it's going to be opposite.
So She was talking about flaccidity with this one though too,
Oh, so well, that could be different, yeah.
so.
I'm not gonna get into
Okay.
acidity yet with these
Okay.
guys. Alright, so positioning. We're gonna use the positioning to help comfort, to prevent those contractions, secondary impairments, but also to help us with our treatment. Let's use gravity to stretch these tight muscles out. Let's use the positioning to prevent a hip or knee flexion contraction.
I can't throw with my left.
Good? So you know what? Let me see what else we have. Let me see.
Little hip.
Yeah, we'll get to, so for lower extremity, avoid hip knee flexion, avoid hip external rotation. So, some of the concerns you want to would be like we showed earlier, because of the pressure. What you can always do is, if you're worried about the hip rolling out for the bony prominences, I can put a pillow or a towel roll to prevent it from rolling out. For RA, avoid rheumatoid arthritis, avoid prolonged immobilization. So with rheumatoid arthritis, with osteoarthritis, they feel better with movement. Motion is lotion. I love telling my patients that. Motion is lotion. You gotta move. For burns or any type of skin graft, avoid positions of comfort. We're gonna get into that much later on, but if I have a burn of my arm, the front part of my arm, I dropped a whole boiling pot of water on it. As it heals, and you've seen you've had scars yourself, the scars heal tighter. Well, I want to avoid that position like this. Yeah, this is a lot comfortable as opposed to stretching it out, but I know this is going to help in the long run because I can regain full motion as opposed to if it's stuck here. All right? So burns and grafts, avoid those positions of comfort because it's just going to shorten them up. All right, let's practice. So you guys do the positioning on each other. Prone, just do the basics first. All right, no, hold on before we do that. Hold on. Total hip replacement. What do you guys know about total hip replacements? Hopefully you say nothing because you haven't learned it. Go ahead.
A lot of times they can't come to 90. Like they can't bring their knee like you can't cross the
Yeah,
plane.
yeah.
So
Good. All right, so total hip precaution. This is for what we call a posterior lateral replacement. Posterior lateral. So you'll see incisions on the side. They go in through the side right here. They pop the hip out, the joint. They cut right in front of the greater trochanter. So now they're getting the femoral head off, because that's where the arthritis is. And then they put a metal piece in, they pop you back together. So the area becomes very vulnerable to our movements, and it becomes weak. So our concerns on a posterior lateral hip replacement is this dislocation. And what we are concerned about would be flexion above 90 degrees. So no flexion past 90. Hip adduction. Bringing the leg in. That's going to expose that new hip. It's going to put it in the area where it's weaker and it could pop out. So no adduction. No adduction past neutral. When I do exercise abduction and I come back in, what's that movement called?
Hip abduction.
induction.
Yeah.
But that doesn't mean I can't do adduction. What it means is I can't do adduction past neutral, that you talked about before. And no internal rotation. No hip internal rotation. So no walking pigeon-toed. So that's great. Your patient comes in, right? You're in the hospital, you're in the rehab center. You see that patient, they had the surgery that day, you're getting them up and walking. Or the next day, whatever it may be. And you're like, oh, hey, Mrs. Jones, how you feeling the hip? It's a little sore, but, I'm ready. All right, just to make sure you have these precautions. No hip flexion, no hip adduction, no internal rotation. She's like, huh? So we know the medical term. We can speak amongst each other professionally and know what we're talking about. But does our patient know? So when we talk about no flexion past 90 degrees, what do you tell your patient?
No
Not
sitting.
bringing that knee up.
So when you sit, your knee cannot be greater than your hip. Make sure your knee is below your hip. Can they do this?
No.
So whether I sit or whether I do this, that's still 90 degrees. So what else do I tell my patient?
No bending or lifting.
No bending. Hey, what else? About no adduction past midline.
Don't cross your legs.
Don't cross your legs. And what else?
Don't turn your toe in.
Don't turn your toe in. So professionally, we know no flexion to 90 degrees, no adduction, no interrotation. To our patients, when you sit, make sure your knee is not above your hip. Do not bend forward. Don't cross your leg. Don't turn your toe in. Hey, you know what? I got one of those old toilets. And so when I go to the bathroom, I sit like this. Is that good?
No.
What do you tell them to get?
A booster seat for the toilet.
A raised toilet seat. Raised toilet seat. You know, I'm clumsy. I drop everything. So can I go down and do this? No, you teach them how to bend properly, or what you can get them.
What's the little grabby thing?
Yeah. Or what you can say, I love these things. Like every kid loves playing with it. You know what? Get the grabber. Oh, I dropped my keys. Pop! I was at the gym. The guy I had treated previously. I was at the gym a while ago. Not many people there. I hear this scream across the room. I run over. I see him on the floor. His bone didn't pop out, but his bone was like sticking out of his butt. Didn't break skin. Knew right away, I treated him, I knew it was a hip replacement. Hey, 911, hip popped out. He went down to pick up a weight. Like this, what movement, so when I'm doing this, what's going on if I'm a left hip replacement? I don't know if you guys can see me. Watch that left leg. That's internal rotation and adduction. He went to pick up a weight and the hip popped out.
No, this was like way after you treated him?
This was after.
So,
It's rare, I'll say rare. It's quite infrequently that the hip will pop out after like 6 weeks. So those precautions, we'll tell the patient, you really want to be careful of them forever. The doctors will say, hey, 6 weeks, you're good. I've had both my hips replaced, and I can, I can do all that stuff. And I'm not concerned about it popping out.
yeah.
But yes, there are conditions where it can pop out. But especially early on, we want to be 100%
Yeah.
aware with these.
So you said you could show them how to bend properly?
Yeah,
Just like at the knees?
no,
Or-
I do what we call a golfer's pickup. Because even if I bend at the knees, and we're going to get into biomechanics and lifting Monday, if I bend at the knees the proper way, like this, I can still get 90 degrees. So if I'm a right hip replacement, I drop my keys. I'll do it on this side now. Am I getting anywhere 90 degrees here?
No.
What they call a golfer's pickup. You ever watch golfers?
Oh yeah, that's
They go
right.
down, they pick the ball up. They'll have like one leg behind. If I do that, I'm nowhere near 90 degrees. That's how I would teach them to pick things up. So now that ties into positioning. We go back and we talk about our position. concern with that patient sleeping. Hip abduction. Right? They I sleep on my side. They sleep like this. She's a right hip replacement. What position is that in? That's an adduction. So now I have an abductor pillow. Keeps me in abduction. So your hip replacement patients will have this. They're going your back. So usually early on they're only going to be lying supine. So they'll be like this. This gets tied down. Okay, let's roll to your side. That stays there because that keeps us in abduction. It prevents us going to adduction. So we'll have an abduction pillow. So when we have our scenario and it's a hip replacement, you better make sure that you have that abduction pillow with you. Okay? And we'll have this out for you guys to use. Abduction pillow. Avoids that adduction when they sleep. We don't know what goes on when we sleep. Chances are you're not going to sleep much, but anyway, that might happen. All right? Questions with that? You also have an anterior approach to the hip. So mainly they used to do posterior lateral, now doctors are doing anterior approach. Some doctors like doing it because there are no precautions for that. However, you still need to be aware of some movements. And so now if they cut in the front, and if the front of the hip is weaker, what position or what movement would you want to be careful of? Because that'll bring, so when my leg goes back, the head of the femur is going to come forward. So what position would that be?
Extension.
Yeah. So I want to be careful of extension because that could cause like stress on the front part, and it can dislocate there, but very, very, very rare. So if you see an anterior approach, really want to find out from the doctor if they have any precautions. I have some doctors that say no precautions. I have one guy that says no extension or abduction for some reason. That's only for a couple weeks.
Question: assuming the doctor says no precautions, and something does go wrong during treatment, is that the fault of the doctor or like?
Well, it's never the doctor's fault. Never. Is it? It depends. You know, what have you done? Some people are just, certain populations will just have, a vulnerable area. It'll just be weak. So no matter what you do, you could have done everything right. Doesn't matter that it could have been just.
Yeah, it's
just
like
happened.
something just happened to go wrong.
Right, but as long, put it this way, if you're doing gentle exercise, I did passive range, you're documenting, I did passive range of motion, we did glute sets, quad sets. I stood with max assist or, whatever it was, and everything goes right, you're fine. I had a case with me where I had a guy who had a knee replacement, and I was just doing weight shifting, which is something you normally would do. And then I had him in his walker lift one leg up. Again, it's a process. Total knee replacement, everything should be fine, weight shifting. When he went like this guy was like 6'5", he was huge. That knee gave out. Opened up the incision, 911, get in the hospital. I'm going back and forth to the doc. I document what I did, weight shifting. Doctor is like all over me. That's too aggressive. And I'm, with my supervisor, I'm like, let me ask you, what would you do? Like, what exercises would you do? Like 2 weeks after knee replacement, weight shifting is very simple. I think he had a quad tendon rupture or tear before, because he had other stuff going on. He had neurological problems, Lyme disease. He was a Vietnam vet who was exposed to Agent Orange. So there's a lot of stuff going on. I mean, I'll take the blame. I don't care as long as I got the guy, as long as the guy got better, which he did. But I was, I thought what I was doing was simple stuff. The doctor said that was way too aggressive. Of the hundreds and hundreds of total knee replacement patients that I've treated, I've done weight shifting on the very first treatment.
Right.
Because they're allowed full weight bearing.
Yeah.
For this guy, it buckled. So it's gonna happen.
And not to mention the hundreds of knee replacements that he did, and those exercises were always used. Or,
Absolutely,
you know,
absolutely. So, whatever.
yeah.
It's gonna happen. So as long as you're doing stuff within what you think is that, that correct plan of care,
Yeah.
then you're fine. You're not gonna do, hey, let's do some, plyometric jumps 2 days after a knee replacement. You're not gonna do that.
So if the doctor said no precautions, would you just like follow those precautions anyway, just to be safe?
If you wanna be safe, yeah, you could, certainly, if you wanna be safe, there will always be precautions on a posterior lateral. If you wanna be safe and adhere to the same ones with an anterior, you're fine. It goes back to early on in the discussion, I'd rather be safe than sorry.
Yeah.
All right? We good? So let's practice our positioning with the pillows.